Hello and welcome. You're listening to Oath and Staff, a podcast about human stories from people of medicine. I'm A. David Singh, your host, former neurosurgeon, and author of Magical Rome Universe. When I'm on this podcast or writing fiction, I explore the same themes: service mindedness, overcoming challenges in a complex world, and how our choices shape who we become. In today's show, I'm talking to Dr. Ravi Kannan, a renowned surgical oncologist. His story begins 20 years ago when Dr. Kannan was working at the prestigious cancer center at Chennai, South India. However, the universe had different plans and guided him across the country to Silchar in northeastern state of Assam, where Dr. Kannan built a people-centric model of compassionate cancer care. During the last 19 years, he has served as the director of Cachar Cancer Hospital and Research Center, which provides medical and social care to millions. He is also the recipient of Ramon Magsaysay Award, often called Asia's Nobel Prize, as well as the Padma Shri. The Padma Shri, as you might know, is a high civilian award given to Indians who have made distinguished contributions in the arts, literature, science, medicine, and social service. Today, I am truly excited to talk to Dr. Ravi Kannan on the Oath and Staff podcast, where you will hear about his remarkable journey as a medical doctor, the core value he practices in the service of humanity, and how the Kachar Cancer Center provides hope and healing for marginalized and underserved communities in Northeast India. Welcome, Dr. Kannan. Welcome to Oath and Staff.
Thank you. Thank you for inviting me this evening.
It's my pleasure. Dr. Kannan, I was thrilled to hear your TEDx talk at Assam University titled, You Don't Need to Be Powerful to Bring a Change, in which you had spoken about the origin story of your hospital. Would you please tell our viewers and listeners about the beginnings of the Kachar Cancer Hospital and how the title of your TEDx talk ties in with the origin story?
In the late part of the last century, in the 1980s and 90s, the only cancer center in the northeast was in Guwahati. That is about 350 kilometers from Silchar, where I am. And those days, even today, it's a challenge sometimes to get to Guwahati. But those days, many of the bridges were not there. The roads were not like what they are today. And so it used to be very difficult for people to travel to Guwahati. And cancer was a common problem in the region for a variety of reasons. And almost every family will have somebody or the other with a cancer. And then you also know cancer treatment takes a very long time to be completed, and results are often uncertain. And so for people to travel to Guwahati or to Kolkata and stay for 4 months, 6 months was a tall order, and many of them would defer treatment. They would come home to die. And so local lay citizens of the region, decided that this was not okay and took matters into their hands. Teachers, lawyers, tradesmen, farmers, engineers, they joined hands, a very small number of doctors, they joined hands and formed a cancer society, Cachar Cancer Hospital Society. And then they went about, door to door seeking support. They held street corner shows. Ordinary rickshaw pullers gave them a day's wages as a donation. They went, sought support from different political leaders. And the local MP at that time was an influential minister in the central government. And so he got them land. And in 1996, they actually opened a hospital. And, the hospital was initially sustained by local surgeons. Dr. K.P. Chakravarti He's around today also. He's 94 years old. He was a ophthalmologist and a joint director of health in the government. He had just retired, and in 92, the members of the society requested him to join. And so when the hospital opened, he opened textbook on oncology for the first time, self-trained himself to deliver chemotherapy. So people would go to Kolkata or Guwahati and come with prescriptions for chemotherapy. So he would deliver the chemotherapy and send. That's how the hospital started to function. In sometime around 2000, the then director of the hospital, Dr. Chinmoy Chaudhary, visited a number of cancer centers to see how a cancer hospital has to be organized. I used to be working at the Cancer Institute in Chennai, and he spent several months with us there. The Cancer Institute had a policy that nobody should be denied treatment for want of resources. We would treat everybody whether they could pay or not. And Dr. Chaudhary was very, very shaken up by this philosophy. So when he came back, he would frequently call me and send patients to Chennai all the way from Silchar for treatment. It so happened that in 2006, sometime in October or November, I quit the institute suddenly. Some small problem, and I was young. I just walked off. And Dr. Chaudhary called me just a month later for some patient. I said, I'm no longer there, but you send your patient. I'm sure he will be taken care of. Oh, you should come here at that time. All we knew of Assam were bombs and flood. So Sita, my wife, said, no, hey, we are going there. No, any place on earth but Assam. Then these people, the society members would call frequently every weekend they would call. Those days there were those PCO booth, for long distance call. Sometime in April, I told Sita, let's go and see the place once. So Sita, my daughter, and I came on a visit, and we spent a week here. I spent time in the hospital, and Sita went around this community. The society members took her around. We went visiting schools, and school principals were so supportive. Doctor, come, your daughter will get admission. She was in class 4. She was in a school that did not have examinations. Every year she would go and she would go on to the next class. What did you do today? Appa, I played. And so when we came here, I said, she doesn't know Hindi, she doesn't know Bangla, she doesn't know Akamya. Don't worry, doctor, children are very smart, they will learn. The local KV principal, I am a Kendriya Vidyalaya product. The local Kendriya Vidyalaya principal was Hari Singh. Hari was my batch KV passed out. I passed out from KV Tambram. He passed out from KV Kapurthala. And so in 2 minutes, we had our common educational ancestry. So, Ravi, your daughter will get admission because of 1, 2, 3, 4. He rattled out several reasons. She had to take an entrance exam. That's a different story. But then, before we could go back, Sita said, there is a lot of need here. This is what we should be doing. And so when we went back, she resigned from work. She used to be the regional officer at USEPI in Chennai. She resigned from work. She initiated conversation in both our home. Both sets of parents were dead against especially our mothers were dead against the idea. My colleagues, they were very, very concerned for me, that this may be professional suicide. But they were very supportive, I have great colleagues all over the place.
Thank you for sharing that very personal story about you and your family. And I was equally impressed by how the local community of Silchar got together and started this hospital to serve cancer patients.
Very inspiring.
Very, very inspiring indeed. So let's talk about the hospital. Would you tell us about the mission statement and core values of the Cachar Cancer Hospital? And what is the target population that your hospital serves?
See, our target is people at the bottom of the socio-economic pyramid. If somebody with money comes, we will treat. But our target is people who are marginalized, who are at the bottom of the economic ladder, who don't have resources to go elsewhere, who don't have social support structure. That is the target of the hospital. So our mission statement is that we want to prevent every cancer that can be prevented, that nobody should be denied treatment for want of resources, that nobody should die in misery and pain because of cancer, and most importantly, no family should be impoverished because of treatment induced expenditure. And core values is something that all of us sat down and wrote together. We had several brainstorming sessions. We took a whiteboard and wrote down all these values. We said compassion is our most important core value. What does it mean to be compassionate? What we will do, what we will not do. And then we said our next core value is we will be pro poor. We want to now change it into pro people, but it is pro poor. And then we said we want to be evidence based. We want to be scientific. We said frugal innovation is very important. We are in an underserved community. We are, starved for resources. But just because we are poor doesn't mean we have to deliver poor quality care. We have to be innovative to be able to deliver good quality care. And then we said we will value teamwork. We are a great team. Today we are about 500 of us, and each of my colleagues is a hero in his or her own right. Every one of them is a hero for me.
Dr. Kannan, would you please give us a brief overview of the structure of the hospital, the staff, departments, and the main activities that take place every day?
See, when we started, we were a small team of about 23 people, and we didn't have the resources to do a master plan and implement it. So we grew organically. Today there is a need. We put in place a structure to solve that problem, institutionalize it, and move on. And then there are problems, we firefight. And all these years, that is practically what has happened. We have now 500 people, and we have all the standard divisions for taking care of cancer patients. We have a very strong preventive oncology division, very, very large community presence. We're in several communities in the districts around us. We have a, good pathology, radiology, molecular oncology, good diagnostic services. And then we have treatment, medical, surgical, radiation, palliative care. And then we have a good research unit. We are a teaching service. We have courses in nursing oncology, surgical oncology, palliative medical, and these are increasing. And then there's a research facility which takes care of both basic research, epidemiological research. We now have a um, research administration unit, clinical research secretariat, and then support services, dental surgery, blood bank. We have, I think the most important part of the organization is our outreach into the community. From 140, 150 beds in the hospital. But then a lot of people are not able to come to the hospital. There was a time in the initial year when we realized that most patients, nearly 60% of patients, did not even come for a second hospital visit. They would come and then they would go and not come back. And even those who started investigations, less than a quarter of them completed treatment. And so we put in place a number of measures. We reduced the costs of care. We fast forwarded investigation treatment because they're all daily wage earners. For them, a day lost in the hospital is a day's wages gone. And so the family starved at home. So we said, no matter what happens, anybody who comes to the hospital will be seen the very same day. We never tell them that there are no appointments, go and come back another day. Because what will happen? They will go back home or they will stay in a public space in the railway station or bus stand and come back the next day. We said core investigation should be done Same day, the blood biochemistry, X-ray, ECG happens. Next day morning, he has his endoscopy or biopsy. Following that, he has the imaging, and he comes back the next afternoon. All our pathology reporting, I have amazing pathologists as colleagues. All our pathology reporting happens on frozen section. And so by the time they come to us in the afternoon, the diagnosis, the staging, and the treatment plan is ready. And then they will go back home and plan what is to be done and come back. And it also gives us time to look for support for their care. And so we put in place a number of measures. Some of the one of the most important things, is see, because of a project with the CDAC, we started testing 2 satellite centers because CDAC, wanted to test a telemedicine software, and they wanted to test it in the Northeast, and they worked with the local NIT that chose us as a clinical partner. And so we put up a satellite center in 2 of the districts around us, in Karimganj and in Hailakandi. We now have 6, 7, 8 satellite clinics around us, and we run these centers so that patients don't have to come to the hospital for everything. A lot of work happens in the satellite center. Similarly, we also have a very aggressive home care program. Home care was originally started for people with incurable disease who are dying of the cancer and are not coming back to the hospital for palliative care. But their services have now increased, and we go to homes of populations. In villages, what happens? The community will typically come and see what's happening. And so they're a captive audience. So after the home care program is done, they will get sort of onlookers and talk to them about health, about cancer, early detection. And through this awareness, patients come up and say they have a lump in the breast or they have a difficulty in swallowing, and we identify cancers among these people. And then the home care program also started visiting homes of people who are not coming back to the hospital, try and understand what we can do to help them. And then the third thing that we do is through the community oncology program. We have a very large community presence. We have presence in several districts around us where we work with the government, with the NHM, with the ASHA. The India has a system of accredited social health activists called ASHA. ASHA means hope. And they are community leaders who are basically mobilizers for health program. And so we work with them to promote awareness for early detection, for palliative care, a variety of activities. And what we learned is in order to treat poor patients, not only do we have to provide low cost, good quality, quick treatment, but 24 by 7, we have to demonstrate that when we say we are pro poor, we are really poor. The way we talk, the way the hospital facade is, the way we dress. Somebody stops us on the corridor, we have to stop immediately, attend to their problem. If I am not able to attend to it, I must take him or her to somebody who can solve the problem. If I were to, brush them off and tell them to come to the clinic or some other place, they will withdraw into their shells and they will disappear. One rude word, they don't have the the courage to stand up to, you know, anything that is difficult to manage. And so every activity of ours has to reflect this pro-poor stance. Even today, despite all these measures, 30% of patients don't come back for treatment. And so that is a very big problem, bother for us. The other thing that we are looking at is, when we treat poor people, we realize that even though in Assam education for kids is free, their kids will drop out of school because there's nobody to earn the daily bread. Kids have to go out to work. And then a large number of them don't go back to school ever. It means another generation is ruined. And so we're actually bothered about 2 of these problems. One is how do we prevent loss of education? And we're exploring a variety of ways to see how we can get these kids to complete schooling and look at higher education. The other thing is they're all small jobs, daily wages. And so when they go through cancer treatment, many of them don't go back to productive livelihood. There's loss of livelihood. So by treating cancer for a breadwinner, we've actually created a problem for the family, another mouth to be fed. And so we're now trying to see how we can ensure livelihoods for these families. Again, we are trying to do a number of things.
So you're providing both medical care and social care to the community through the hospital.
So you know what? I really think that you cannot provide healthcare as a tunnel, because healthcare, education, livelihood, environment, so many of these factors are so intimately one is linked to the other. If you look at if you look at providing education, ignoring the health aspect, you've lost the game. If you provide health care and ignore the loss of livelihood, the loss of education, you've lost the plot. We have to look at it wholesomely. We may be able to do everything on our own, or we may find partners who will work with us to do this.
Dr. Kannan, thank you very much for sharing those deep, deep insights about the work, the remarkable work that you and your colleagues are doing at Cachar Cancer Hospital. So I was wondering, how do you divide your time between surgical care of patients and running the hospital?
Clinical care takes precedence all the time. The patient in front of me, or the ward round that has to be done, or surgery that has to be performed. I have very good colleagues in accounts, in administration, in information technology, in resource mobility. And so they more than make up for my ineptitude.
Well, I am sure that's not the case.
No, that is the truth.
So let's go back in time. When you moved to Cachar Cancer Hospital 19 years ago, what were the initial challenges you faced in your role as director of a cancer hospital, and how did you resolve those challenges?
When I look back in hindsight, the biggest challenge for us probably was the fact that we didn't know anything about administration. We didn't know anything about economics. All we knew was taking care of sick people and operating and working with colleagues to make sure we deliver multidisciplinary care. That's just about what we knew. And so we learned everything on the job. I didn't know how to manage nurses and cleaning personnel. And you won't believe, we were only 6 nurses when we started. None of them was formally qualified. Okay. And very quickly we started having A&Ms and GNMs, and when we were 30 or 35 nurse strong, there was a government call for nursing positions. And suddenly, 25 of them disappeared. Overnight, 25 of them resigned. And suddenly, from 35, we were down to 9 or 10. And then we sat down, my nursing supervisor, who was there then also, Sarita, we sat and took a decision that at all times, 50% of our nurses must be the traditional nurses that we had died, who were trained on the job. And so today, for statutory reasons, we are now 240 nurses, but even now, 120 of my nurses are qualified. It meets all the statutory requirements, and half my nurses are still the old die trained nurses, but they are brilliant. They're like sponges. They just didn't have the opportunity to learn and grow. They are paid better than any die nurse in the community. They have respect. They see value for what is happening, and they hold the backbone of the institution together. And then things worked out. I have great, tremendous people as colleagues, at all levels, right from cleaning staff to technicians to nurses to doctors to administrators. Amazing set of people who have joined us.
That's a very inspiring story, Dr. Kannan. Thank you for sharing that. When we were talking about getting you on the show, I took the opportunity to do some research. In one of your videos, you had mentioned that cancer is a lifestyle disease. Would you please tell our viewers and listeners about the different kind of cancers that can be prevented by making healthy lifestyle choices?
If you look at India, broadly speaking, 60-70% of cancers are caused by lifestyle. Head and neck cancer, esophageal cancers, gastric cancers, breast cancer, cervical cancer, all in some manner or the other caused by lifestyle. You know, Tobacco. Tobacco is a very big problem even today, especially chewing tobacco, very big problem in the country. Though the last survey shows smoking has reduced, except for 3 or 4 states. Chewing tobacco is not counted. We don't have any idea what's happening. And then alcohol. Alcohol is a very major problem in many states in the country. And then the dietary choices and dietary preferences, how we make the food. Now there's a lot of processed food coming into the market. Physical activity and across the board, physical activity has come down. When we were kids, we were always on the street cycling, swimming, playing. It seems to have disappeared. Kids are on their phones and their computers, and there is a change in lifestyle. While they are eating a lot of processed food, they are exercising far less. Tobacco, alcohol accounts for a whole lot of head and neck cancers, esophageal cancers, pancreatic cancers, the urinary tract cancers, gastric cancer, diet implicated, colorectal cancer, breast cancer. So many cancers are because of our lifestyle. Now, for a second, keep cancers out. If you look at heart disease, which is the commonest cause of death in the country today, both strokes and cardiac diseases, what aggravates diabetes or hypertension, peripheral vascular disease, COPD. So many non-communicable diseases have the same set of causative agents. So when I talk of cancer prevention, when I don't use tobacco, when I don't drink, when I eat healthy, exercise regularly, take care of infections and inflammations, I prevent a lot of cancer, but I also prevent heart disease. I prevent stroke, diabetes, hypertension, COPD, peripheral vascular. So many diseases are prevented. In other words, we're actually promoting health in the community. And this is something that does not have to go out from the doctor or the nurse. This is something all of us can do, talk about in our own spheres of influence in our communities.
Thank you for that. That's a public service announcement, and I'm happy to share it widely across both video and audio podcast channels. Another video which I saw of yours was your presentation at the I Discover oration at my alma mater CMC Vellore. In your erudite talk, you had stated that your hospital is an institution at Crossroads. Dr. Kannan, would you please tell us about the key issues that are being considered and discussed by you and your colleagues at this crossroad?
Yeah. So there are many changes happening in society around us. And so if you take my own colleagues, when we started off several years ago, many of us were very young. Many of my colleagues were not married. They've gotten married, they've made babies, their kids have to go to school. They would like to construct a house. They would like all perfectly reasonable requirements. But all of it costs money. We serve a very poor community and they don't have the capacity to give us the kind of money that my colleagues sometimes need. And so it's a perennial debate in the hospital, that just because we treat poor patients, should we remain poor? That's not a fair expectation. And so, there is this argument, that we must raise charges. So these are difficult arguments to settle. You don't want to hurt patients, but you also don't want to do injustice to your own colleague. And how do we make both ends meet? When we start, we are all very passionate. We are all mm, motivated by a cause. And then as we grow, as we our families expand, our social needs increase, there is some divergence. I say we must all see all patients that come to the hospital every day. Now they want to go home, they have their own kids, they have their family. And so there is some dichotomy, they don't want to stay on longer. And so it conflicts with our core value of compassion. Patients have come, spend a lot of money and come here. They cannot afford to stay overnight. They will lose another day's wages. There's no right or wrong answer. but these are issues that we must settle in the long term. I used to think that, people who join us today are people who have not seen the struggle that we have gone through in the past. I used to think that youngsters who join today are probably the reason why our core values weaken. But the truth is, it is the leadership of the organization that actually contributes to a very large extent for weakening in core values. When I when I when I overlook, inappropriate behavior by somebody in the organization who I consider crucial, then I'm sending out a message that these core values are negotiable. And then what is happening is, so we were the only hospital in the region, and soon there will be other hospitals coming up. The idea of poverty itself will change with time. And so when there are other hospitals coming up, some of these hospitals have glitzy paintings and tiles and fountains and all the razzmatazz. Then people say we would like to be like that. But that is at variance with what our core population, target population is. It is important for differences to happen, and it is very important for differences to be spoken about. And then, see, we served a very poor population. And then what has happened? The government insurance has come in. And so there is some money at the bottom of the pyramid. There are for profit organizations which would like to share some of the money at the bottom of the pyramid. And so, for a variety of reasons, patients will go to other organizations. And then they will lose all their resources. And then they will come back to us without anything in hand. And so then there will be an argument, oh, this patient has gone elsewhere. He has spent all his money. Why should we take care of him now? So, yes, in one sense, that argument is correct. But on the other hand, it is not about the money that the patient has, it is about the need the patient has. So, so the community itself is at crossroads because the whole idea is changing. This morning we had a staff meeting in the hospital. We had a long conversation about how we continue to stay true to our core value of taking care of poor patients. But if we have to take care of poor patients, we have to make sure that a critical mass of poor patients continue to come here. If they are all going away, how do we stay relevant to the needs of the community with changing times? And now with technology, with AI coming in, everything is going to change. And so how do we empower ourselves to deal with all these changes?
An organization that serves people, like a hospital, is dependent on its relationships with the community around it. As the head of your hospital, what initiatives did you develop to build and retain the trust of the local community at Silchar?
The truth is, we didn't do anything consciously. We did it, you know, without knowing that that is what we were doing. People would come and ask us to come and address meetings with the community. We would happily go. We have a very large community participation. And then we had an administrative officer who was a retired school teacher. The society posted him as our administrative officer when I joined in 2007. That man was probably the single Mr. Kalyan Chakravarti. He is the single most important reason for the hospital's growth in the last so many years. The man had a knack of interacting with people of all shades, from different opposing political parties to different community groups, different religious groups, different academic institutions. He had a knack of managing everybody on very good terms. He would frequently go out into the community and then say, "Doctor, come, you have to go and speak at this meeting." Doctor comes. Whatever he said, we would follow. And that is one very major reason why we have a very large, uh, very good equation with the community. And now he retired and we have younger colleagues taking over. And one of the things that we are trying to teach our younger colleagues is to build that community partnership. Another example, how we serve the community. See, blood banking used to be a problematic thing. Patients would often bring paid donors. Blood would be donated, and then blood banks would sell blood at a cost. So when we started the blood bank, we took two of the major policy decisions. We said, number one, we will not ask for replacement donors. Entire blood should be voluntary, because even my wife needs a cesarean section. If I need blood, I need blood immediately. At that time, if you ask me to go and get blood, what will I do? I will find the first fellow who will give blood. If I pay him some money, I will ask him to come and donate blood. If my father has a fractured femur and I need blood for him, if you at that moment of crisis, if you ask me for replacement, I think it's a very cruel practice. And so we said all our blood donations must be voluntary. The second thing we said is we will not give whole blood. So we started a policy where we will only give component. At that time, this was not such a prevalent practice in the region. And so we were able to reduce the cost of whatever we were spending for the blood to a third, because we had plasma, we had RBC, we had platelet. And so we were able to reduce our costs and pass on the benefit to people who needed blood. But then it needed community donors to come forward to donate. And so Dada went about evangelizing blood donations. And now we have multiple camps every week, and we are never short of blood for patients. The community helps us do this. So we during COVID, we didn't have access to all these N95 masks and all that. And then we had several medical bodies advising multi-layer cloth masks are good. We sent out an appeal, that we need cloth to make masks, and we got bales and bales and bales of cloths from different vendors in the community. And so we made masks for our staff, for our patients, for community members, for everybody. There were floods, horrendous floods 2, 3 years ago. The whole area was underwater. And then ours was the only kitchen running in this village area. And so at one point of time, 900 or 1,000 people, we had people who came and gave rice and dal. And so we would put all of it, make khichdi, and we supplied the whole campus. So the community comes forward to support us for a variety of activities. And it is symbiotic. We support the community, and the community supports us back in return. And I think it's a very good feeling at the end of the day.
Certainly. During the last 19 years as director of Cachar Cancer Hospital and Research Center, what would you consider are your biggest rewards?
My biggest rewards are my colleagues. I didn't bring any of them to the hospital. They all, one by one, they all came and joined us and added value to the system. They grew and they helped the system grow. The second biggest reward, I think, are the friends that we have built, friendships that we have built across the country and elsewhere. We have a very large number of people, medical, non-medical, who support us in so many ways, big and small ways. And they may be donors, they may be CSR partners, they are medical colleagues of mine. And I think I keep telling everybody, it is more important to be friend raisers than fundraisers. And the friendships that we have formed we have forged with different people across the country is a very big reward for me, I think. And then of course our own patients. Some of them will become well and they will come back and invite you for births and weddings. And also patients who don't survive, their family members will come back to more patients. I came to the ward to finish round before going home, and I found this man lying very sick. He is a young 30 odd years. He had a metastatic lung cancer. He came with pericardial effusion. So we did a pericardiosynthesis. He became well. He became better, and we sent him home on some oral drugs. A few days later, again one evening, I come and I find him there, low volume. Was very sick again, reaccumulation. cardiac tamponade. So we took him to the theater and we did a small pericardial window and created the pericardio-peritoneal communication. He became well. His only question, he had a newborn son at that time. And in the Bangla community, at 6 months, they have a ceremony where they feed rice to the baby for the first time. So he wanted to be alive for that ceremony. And and so somehow he lived, not because of me, but he lived and we were invited for the ceremony. 2 months later, he died. His wife, who used to be there, at some point I lost connection. About 4, 5, 6 months ago, I get a call. She's now somewhere in Delhi or somewhere. She's gotten married again. Her son is now a big boy. And she called to tell me that the son is now joined engineering just out of the blue. And so these moments make you feel that, even if you have failed to save somebody's life, she spoke about that her husband and about the Annaprashan. And so these moments affirm the value of what you're doing. Those are my rewards.
That's a very touching story. Thank you for sharing it, Dr. Kannan. I had the opportunity to interview another cancer surgeon who is my batchmate from CMC Vellore. Her name is Dr. Shalini Mishra. And I believe she's known to you.
Yeah, you're a good friend. She supports us
Good.
in our pediatric oncology work.
Right.
You don't have a, see, this is the idea of, this is what I meant, friends. We don't have a pediatric oncologist. We don't, but we get kids with leukemias and Wills tumors and osteosarcomas. And so we constantly need round the clock advice. And so few of our pediatric oncology colleagues across the country have created a group, and every Saturday they would do a tumor board to advise us on how we should manage. Shalini is one of that group.
So when I was talking to Shalini, who was kind enough to come on the podcast, and the same question, what's your biggest reward? She gave the same story as you, that the children that she treats as cancer patients, they become well. They join professions like medicine and engineering, go on to have families, and then they bring their children to meet her. So that was a very touching story, and I'm hearing the same story from you. Dr. Kannan, I was wondering, what is your vision for the Cachar Cancer Hospital after you hand over the reins? And how will you ensure that the core values that you practice are maintained by the next generation of leadership?
So I think the challenges that every generation will vary, and we cannot be prescriptive for future challenges. Future generations will find their own challenges, make their own choices, but the value systems, the basic core values cannot change. And so we are now we have several programs in the organization where we talk to our colleagues, we get people from outside to come and talk to our next generation of leadership. Our vision is, that the hospital must be firmly rooted in the community. So long as we are true to that vision, I think we will be fine. Now, government of Tripura gave us 15 acres of land wanting us to replicate a hospital in North Tripura. Somebody gave us land in the middle of Karimganj, about 2 acres of land. We're trying to see if we can get something going there. So whoever takes over will have to make sure that our engagement in the community becomes deeper and more meaningful. The challenge of continuing core values, continuing to keep the mission of the hospital of being inclusive will fall upon his or her shoulder. And I think the biggest challenge will be for the new leadership to look at technological progress that will happen in information technology, in biotechnology, because many things will change over the next 10, 12, 15 years. And the leadership has to be adapt at adopting and adapting changing technology so that we are not left behind. And so this is what I think is needed for the next leader.
From your vast experience as a surgeon and director of your hospital, what is the one key inspirational message that you would like to share with medical students and young doctors around the world who are just starting their careers? Please give us one pearl of wisdom.
We're all born unequal. For whatever democracy, whatever we say, we are born unequal. Some of us are born into wealth. Some of us are born into families that are very high academic achievers. Some of us are born with a lot of skill set. And some of us are born with nothing. We are born to, you know, rickshaw pullers and fishermen and none of us chose to be born where we were born. Some of us had opportunities by virtue of the fact that we were born in a family that could give us those opportunities. And some of us were born in places where, you know, there's nothing. This was done by God or whoever deliberately. He gave some of us more of wealth and education and skills and opportunities and talent and gave others less because he trusted that those of us who have all this, what little we need for ourselves and use the rest for people who don't have. And I totally agree, that I was born into privilege. I could go to school, I could go to college, I could become a surgeon, I could become a cancer surgeon, I could come and sit on a podcast and talk to you like this, all because of where I was born. And so, whatever I can do to use my skill for the benefit of people who don't have any of these things, I think it is a responsibility that I have. And that I think applies to all physicians.
Dr. Kannan, it was so wonderful talking to you. I had a great time getting to know you and the remarkable work that you're doing in the service of humankind. Many thanks for coming on the Oath and Staff podcast.
Thank you. Thank you very much. The privilege is all mine. Thank you. Thank you, David.
And that's all for today, folks. I hope you enjoyed this episode with Dr. Ravi Kannan and also found it inspirational. Thank you for tuning in and subscribe for more.